we're going to be having a bit of a chat, and I think other members of the panel may join us, which will be excellent, to actually discuss an audit report. And first of all, Joe, thank you so much for your support and help in getting the audit reports working. And your practice being one of our earliest big guinea pigs, or practices being one of our earliest big guinea pigs for the audit. So what I'd like to do is just go through the format of that report online. So everyone should have had it as a HTML report, which makes it interactive. And so here is the report. So I'll start at the top because I'm right into the middle of it here. But this is based on a electronic medical record automated data extraction, analysis of that EMR report, and then potential questionnaires to high-risk asthma patients, or to those on however you want to design it in your practice. So the idea is the process should be as automated and as easy as possible, as opposed to many of the audits that go on. So very much a practical, hopefully helpful program for people. So what it does at the top, it gives the number of active patients, how many have asthma, and typically we see about 6% of patients are properly recorded as having asthma or active. We see that 11% were high risk here of the asthma patients. And then we see some of the metrics in terms of what's been coded as happening. Now, at the moment, we work only with coded data, but in the near future, we'll also able to work with free text data through some redaction of all patient identifiable data. And we can see the proportion of people who have active asthma, who've had lung function testing, 4%. A little disappointing, maybe. And we can see that 14% have had 2 or more SABA prescriptions, what's actually really authorizations. And smoking status recorded. So this was the actual first report. Zoom in, I've been told. Apparently my screen, I love my screen on a very detailed resolution. So instead we're going up to, okay, hopefully that's clearer for everybody. We can see the proportions of these things, and you can also click on certain aspects of this as well and get it, it's interactive. So there's a simple description of the actual report, the key management areas, and then also some patient reported data with some questionnaires. The bit that I think is most interesting is the high risk patients. So this is the proportion with 2 or more exacerbations, or 3 or more exacerbations in the 2-year period. And then clicking into the issues that were raised this morning about high SABA use patients. These are those who've had multiple SABA authorizations in the practice. So this is the authorizations of prescriptions. And then this is the breakdown of those high risk patients. What do they look like? So some of those are smokers, not many. 15% of active rhinitis, which very much ties in with what Richard was talking about. 62% allergic. Only 3% have got lung function testing. 15% are logged as having an action plan. And a small number have been referred to a specialist. So maybe, Joe, I'll get you to come in here because you've actually been working with this type of report. And what did you do with this issue of these sort of high-risk patients that get identified? And further down in the report, it tells you who they are. But what have you done with this?
So with those sort of high-risk patients, we started to identify them. We then actually sent out a questionnaire for the patients that we wanted to get their feedback on the surveys and qualitative about their symptoms. And then we waited for that sort of survey to come back. And then we actually got our practice manager and our nurse to actually get these patients back to see the GPs. And I think every practice would have those high risk patients that they need to get back to see what how we can actually improve in their sort of respiratory care. One of the good things that I found from the OPC approach is that the automated sort of data reports actually highlighted some of the steps to look at. And I think, for example, one of the patients, one example was that to get the patient's review with the medication, doing the asthma plan, and those who have been higher risk, you actually assess them in terms of whether or not they need to see specialist referral and so forth. Obviously, during this COVID sort of thing, we weren't able to do any respiratory sort of spirometry or peak flows, but yeah, we found that it was useful to get them back and be reviewed with the data that was given to us.
And how did you organise that, Joe?
So we had at a practice level, I organised with the practice manager to organise a meeting with the GPs, and we sort of went through the practice level reports, which is what you got there going through at the moment. And we wanted to focus on these high risk patients. And I think the GPs in the practice, they were probably more interested in what we could identify, but they were wanting to see which patients they could see to do something about it. So the beauty of what this helped was that we could identify those patients that our GPs were seeing. And then basically after that, with the way the report is done is that it's de-identified, anonymized, so there wasn't any sort of confidentiality issues, but the way that the process allowed us to re-identify those patients in the practice. And then we then, through the practice manager and the practice nurse, found out of those high-risk patients, which GP saw those patients the most. Potentially in a group practice, which we have, I'd say majority of the time that GP saw that patient is where we try to highlight the patient review to go back to. So, and then we went through the process of getting the patients to come back to see that GP for the patient review.
So I guess, you know, as we've been rolling this out, I understand what's in it for the GPs. Obviously, there's the 40 points for each of the audits. I mean, there's a COPD 1 and a heart failure coming along as well. And also the fact that they can really focus in on some of their high-risk patients, which I think everyone finds very helpful. What's in it for the practice, though, Joe? Because you run a group of practices, you've got to make ends meet and all the rest of it. You know, how do you persuade your practice managers, etc., that this might be useful?
The practice manager, there's issues around the current practice incentives, which have changed since February to the workforce incentive program, which part of it is that they can get the nurse to do some of the work, which I think is helpful for the practice. And when the GP does the actual reviews, they can actually, each individual GP can use some of the GP management plan item numbers, and so that's been helpful for the incentives. But also, I think that the practice manager, I think it improves from a quality improvement point of view, because there's actually also a part of an incentive piece there for the practice from a quality incentive piece.
Russell, I maybe just throw this to you. So how would you think about trying to implement some potential, because there's quite a lot of things here where it looks like that maybe the practice hasn't been doing things, or maybe it's actually because it's simply been free text coded. You're muted, by the way. So how would you address some of these things, do you think, if it was your practice?
Well, just going back to your last question, I tried to get our practice on board with this, and the IT guy just came in with you can't play with the system. I don't want people entering stuff onto my server. So that's a real issue, is to get it in, is to convince the IT guru that it's a safe thing that won't corrupt your data. And I'm sure you've got lots of practices, but somebody within OPC who could talk to the IT person to get them on side would be a very beneficial plus, just as an aside.
Yeah, no, and actually, the IT the IT team that actually do the data extraction are called Orodashi, and they're also responsible for Telstra Health. So they're actually well over all of those issues.
Yeah. Sorry, getting back to your question about the output. So I think in a practice you can only start to talk to your own statistics. I don't think there's a position in a practice for you to talk to anybody else's stats. So I think it's only your own stats that you should be commenting on. I don't think we should be making comment on our colleagues. We don't understand what their patients are, but as a general consensus, I think we could look at things. I mean, it's your areas of interest with asthma. I mean, eosinophils for me have become very interesting in the last couple of years. I don't have many referrals to specialists for my asthma patients, only if they need a biologic. I think the number.
I'm debating on you there, Russell. Which ones would they be that you'd be wanting to refer on for potential thinking about a biologic?
Well, extremely high IgE, extremely high eosinophils that haven't got worms, people who aren't well controlled, people where no matter what I think I've been doing right, they're just not responding, not coming back into control. They're the groups that I'd be referring on. And also if I'm getting confusing practice spirometry, I mean, the most confusing spirometry that seems to mess up our in-house spirometry is interstitial lung disease and fibrosis. I always get high quality lung functions for those before I start to guess. I think our practice, you need DCLO and more complex functions to really assess them properly, which we can't offer in primary care. I don't refer that much rhinitis off. I think if I can't get them to stop smoking or see the benefits, I don't think anybody else is really going to be able to get in their ear either. So basically, I have more complex COPD referrals than I do asthma. So it'll be in the other questionnaires later on, obviously. But if I'm having struggling with good, reliable spirometry, that's one I always tend to refer off. I don't like to guess. And having worked 1 day a week now for 2 years with really high quality spirometry and complex lung function tests, geez, it makes respiratory medicine a lot easier to practice.
Yeah, and I'm with you on that. I mean, I just actually reviewed several hundred spirometries from a primary care setting from the Netherlands, and yes, the barn door ones were easy. You know, the barn door big reversibilities, the barn door COPDs without reversibility, very straightforward. But there's an awful lot of borderline cases sitting in there in primary care where it's very hard. And I think that's one of the real challenges. I'd say in the UK, I used to use a lot of exhaled nitric oxide, but it's not readily available in primary care in Australia at the moment to assist me. And did you take a view on exhaled nitric oxide within the Australian context, within the asthma handbook, or you're not allowed to tell us yet?
That wasn't in the latest review. That's not my section. I only chaired the mild asthma working group. Okay. So maybe what we'll do is we'll now break out to some of the individual patients that we actually had coming out of this. So I'm just going to change over. Hopefully you can see the audio right now. These are just a couple of comments from other GPs other than Joe who've taken part. Dr. Samuel King is down in Melbourne, and Anita Sharma's up here in Brisbane, who actually have taken part in the process, and I think have found it invaluable as well in their practices. So this was the sort of we've talked a bit about that, and I don't think we've got a question for you on this one, because I think we've talked a bit about how we're going to manage that. But I'm going to go to some patient cases. So this is one of the ones that we got out of one of the audits. I don't know if it's one of yours, Joe, or somebody else's. A 63-year-old male, non-smoker, 3 prescriptions of prednisolone in the last 2 years, no record of inhaler check or FEV1, had an asthma review recorded in October 18, rhinitis is logged, allergies are logged, but no therapy for the rhinitis. And he was on daily low-dose ICS plus ASABA, so GINA step 2 type patient. But then we sent the questionnaire to the patient, and what did they say? Well, they nighttime symptoms 3 times a week, daytime symptoms 4 times a week, using their reliever 5 times a week, 3 scripts for prednisolone, so they agree with what was in the medical records.
They were supposed to be on regular budesonide and terbutaline as needed, and admitted to mostly forgetting to take their asthma medications. So they're taking their allergy medication daily, which we don't know what it is, and they have an asthma action plan. So that was the story for them. And I'm going to put up a polling question now, hopefully, to ask people in the audience what they would do for this. So I might just move that. I don't know, I can move it into the center of the screen. Yeah. What intervention would you recommend? So would you increase this person to a medium dose ICS, change ICS to an ICS LABA, and educate them need to take their ICS regularly, and switch from ICS LABA to as needed ICS plus formoterol, it should say. I don't know how salmeterol crept in there. It should say formoterol. Sorry, it's probably my bad handwriting that got misread. So we've got the increasing to medium dose ICS, change to ICS LABA regularly, educate on the patient on need for proper adherence, or switch to as needed ICS formoterol as one of the options in the new handbook. So can you vote now, please? Interesting. So the most common one was we're going to still encourage them to take their ICS regularly. So Russell, that's very much, I think, what you probably were saying earlier as as a key thing. Do you think it's going to be successful with this patient?
It depends on the level of engagement you've got. And I don't think we can have one spiel or one mode of action that applies across the spectrum of asthmatics. I think we've got to be realistic, and it's what the skill of general practice is. We vote on our feet. We change our presentation or our engagement tools depending on who's sitting in front of us. And if you've got correct technique and you've got correct adherence, then frankly, the type of therapy you're going to swap to is probably not that important if you've got everything else right.
Okay. And Joe, how would you go here? Obviously, it depends on the patient. Of course, it does, and that's the right answer. It depends. Yeah, but so if what would you generally be your first port of call here, and then what might be your second and third ports of call?
Well, it's interesting. The polls sort of show that education was the key, and I think what Russell was saying was that if the engagement is strong, then that's where you need to focus on first, and then the other sort of treatment sort of options, the strategies around that will reflect your second and third sort of approach to increase, changing ICS to combinations and so forth. So it's interesting the poll put down the sort of education piece as the first thing to get them back on board for this patient.
No, I'm actually impressed by that, to be honest. I think it's I think there's if you've got a patient who's never going to take the stuff regularly, then obviously option 4 is probably your best way to go in such a patient. And the ideal would be the regular ICS. I have to say, increasing them to an ICS LABA may actually have benefits too, because it may well be that the symptomatic improvement they get from that could actually drive them to actually be regularly adherent. And I guess the other reason to push is that way is this is a lot of exacerbations. I mean, 3 exacerbations in 2 years. This is a pretty high risk patient, and we know once you hit about 1 gram of corticosteroids in your life orally, we start to see increased osteoporosis and diabetes. So that's certainly this is a patient who's on a rocky road right now. So I think that would be all big issues for me. I mean, where do you draw a line in terms of the amount of OCS before you start getting worried in your clinical practice? I mean, what's your line in the sand, Joe?
Interestingly, I used to use oral corticosteroids a lot more, but since the last couple of years, I think it depends on how often they get exacerbations. But I after 2 or 3 courses, I start to think, well, I need to get some more help.
Yeah. And what about you, Russell?
I had a really good presentation last year, I think it was. someone we might know, but it was around the cumulative dose, and the cumulative dose of 1 gram in a lifetime actually scared the proverbial out of me. And I was sitting next to my director of respiratory medicine from SCU, and his comments were, "Oh my God, how many people's bones have I melted?" So yes, any oral steroids now twigs me as to what am I doing wrong.
Yeah, and I think I'm really. I think we've been flabbergasted by what our data shows, to be honest, and it has shocked me. It really has. This is a patient who, when we talked to their GP, hadn't seen this patient for ages, but this person had a rather odd history: 29, BMI 41, so rather obese. Salbutamol as needed and nebulized as needed, and prednisolone courses as needed. Rhinitis, obviously obesity. 1 ER visit in the last 12 months, emergency room. 4 exacerbations, going all over the place to get her prednisolone. Lots of symptoms. 5 to 8 puffs of salbutamol per day. So the question on this lady, this makes more sense. The question fits now. Reinforce the need for their action plan, but change nothing. Increase to regular ICS. Increase to regular ICS plus LABA. Increase to ICS formoterol as needed. What do we do here with this lady? Here we go. So increase to regular ICS LABA for 70%. What do the panel think about this patient? So, Joe, do you want to go first this time?
Well, increasing the ICS and LAMA, I think she's obviously not using her puffers appropriately, and she's using a lot of relievers. So yeah, she's got problems.
Yeah. What we actually found out is that what had happened to her is she'd been issued a couple of repeats for emergency steroids, and she'd found out that taking a couple of a day kept her very nicely well.
Probably made her hungry
Not
and
all this weight.
Yeah, exactly, weight.
So she basically worked out the prednisolone tablets meant she didn't need to worry about her inhalers very much, and she hadn't been consulting. She's not been bothering anybody. She's was hidden in plain sight. So Russell, what do you think about this one?
I mean, the science would say that the regular mono ICS would probably suit her, but this lady's quite sick. And even though the PBS Australian guidelines mightn't suggest I should go to step 3 in her, I think there's every chance that's probably exactly what I'd do. I actually had a similar case at school last week, and he had a reversibility of 29%, and he'd come up from Sydney with aspergillosis, and he quotes some professor in Sydney saying he can use his steroids for 3 days at high dose whenever he wants, and he was doing that about 5 or 6 times a year. In fact, he's just got rampant out of control asthma, and his IG levels are incredibly low, and in fact, I think he's just been self-medicating like your lady this case was doing. So it depends on how scared I was about her, but I'd go to regular mono as the absolute minimum, and probably straight into step 3 ICS LABA in a smart regimen, not in a PRN, definitely not a PRN.
And what would you guys do about the fact that she's on this prednisolone every day? What would be going on with her adrenals, do you think?
Yeah. You'd want to measure cortisol, and it was a magic number, 200, 400 or something, the cut points, something, David?
Yeah, and it's interesting that I can't tell you the results yet, but there's going to be a trial come out very soon called Ponente, which is looking at using one of the biologics to take people off their long-term maintenance OCS. And it's scary how many people have got very bad adrenal function. And when you, and what's interesting is that probably, I think for the year she may be all right, but it's been fascinating how many people, when you do a synactin test, actually still have impaired adrenal function and are at risk. And the big at risk is often they're fine when they're okay. It's what happens when they get run over by a bus or get a viral infection or whatever, that they actually don't have the ability to manage their lack of endogenous steroid. So it is important. And I think we're increasingly, probably the recommendation is if you can, involving endocrinologists in these patients, whether it be they are more worrying than we realise. Joe, any other thoughts on this one?
No.
Cool, lovely. Well, that was over. I'm glad I got the right question to go with the right patient there. It was definitely looking a little bit odd. Now I get the next one up, hopefully. Here we go. And I'm going to tweak that. It says LABA here, not SABA, sorry. 55-year-old lady. Not so obese, this one. Inhaler technique, good. Asthma action plan. Bloody eosinophil count 400. Awful lung function. For all the world, this looks like COPD. She's on medium high dose ICS plus a LABA. 3 exacerbations in the last year. Reliever frequently, but she's doing all she can with her meds. So we'll bring up the question for this one, if we may. Okay, so the first question here is, what's this lady's diagnosis? So she's got COPD, asthma, or asthma COPD overlap. And the word syndrome probably is something that slipped in from one of my old slides, because we've lost the word syndrome now, because there's no such thing as a syndrome here. It's just they have asthma and COPD together. So I'll be interested to see what people think on this one. And I have a very strong view. It's going to be interesting to see what Joe and Russell's view is. 81% say asthma COPD overlap. Okay, I disagree. Let's see. Let's get some views here. Joe, what do you think?
I was actually going to say an overlap. So tell me.
Why not? Good. I want you to disagree with me. What's your rationale for that?
So the thing is, I mean, she's got like the eosinophil count's high, so she's got some sort of like allergy or atopy, FEV, FEC, 0.5 are less than 80%, 70%. It's significant. There's a restriction there, obstruction. Sorry. Yeah, like to me, it's a bit unclear. It could be both.
Okay. So Russell, what's your thoughts?
Well, I don't think you can make any. You need more information. I mean, you need to know atopic history. You need to know reversibility, which is not stated there. My pet hate is in the respiratory lab that they don't want to do pre and post. Even if you request it, you'll often only get the preliminary. And if they've already had their say it's not on ICS LABA, but say she was, and they've had their LABA that morning, then how can you assess reversibility? So I'd like to know what her spirometry does in reversibility. I'd like to know whether other atopic symptoms. I'd like to know what age she got the disease. She's a non-smoker, so what's going on if it really is COPD? She's one of the 50% who aren't smokers, I suppose. But yeah, you just need more history, I think.
Yeah, and I agree with that. I've deliberately not given you a full history here because I wanted to provoke the discussion. And I think, I mean, my personal take on asthma COPD overlap is to have that, you've got to have both diseases. So to have COPD, you've really got to have had some noxious exposure at some time in your life. Now, this could be somebody who's actually been exposed to a lot of cooking, smoke, and is actually a recent immigrant. I've not told you that, whether that's true or not. Or it could be they're lying about their smoking, of course, which is often happens. But also, this could be severe asthma. In the severe asthma registry that we're running globally, half the patients have never smoked, but yet have fixed airways obstruction of this sort of order, and probably caused by repeated exacerbations over many, many years. And so the data, in fact, Omar and I discussed it earlier, that repeated exacerbations of asthma over 30 years, you'll lose 20% plus, 30% plus lung function. So it's a really big factor. So this could well be severe asthma. It could be COPD and she's fibbing, or it could well be both. So I think it's a great discussion to have. And I think this type of patient needs very careful workup.